Notification, that's a new word. Motivation. Few patients I got to quit cigarettes. Our providers are trained in behavior modification and can prescribe medications. So a lot of what we thought about was how do we provide services that are needed and valued, and because we are a low-cost model, we can be very successful. Now, I want to talk about partnerships. MinuteClinic in the beginning was just a MinuteClinic on the corner. We've changed the model drastically. We have affiliates all across the country. Cleveland Clinic, Emory, Sharp, UCLA, all across the country. We have over 50 affiliates, and we're adding new affiliate roughly every month. The concept is, as we move from fee-for-service to ACOs, bundled payments, capitation, the healthcare organizations need high-quality, low-cost access, and there's not enough primary care out there. And there's lots of people who can help support primary care. So what we do is we integrate our electronic medical record with the electronic medical records of our affiliates. Patient comes into MinuteClinic, they have high blood pressure, but they're there for a sore throat. Or they have diabetes, but they're there for a sore throat. Our provider, with the patient's permission, can open up the record of the affiliate and see what medications the patient's on, what allergies, and that they were recently started on a medication for their high blood pressure. We take care of the visit. We check their blood pressure, which we always do, and talk to them about how it's going, knowing that it's an issue for them. And the record gets sent back to the physician. It goes right into the electronic medical record. It's not just a scan chart, it's not just a faxed. Nope, it goes right into the record, chronologically in the patient's chart. The doc gets a email saying the patient was seen at MinuteClinic and can go into the record. If it's not important, they can just wait till the next time they were seen. That is taking the concept of the nurse practitioner down the hall and putting the nurse practitioner in the community where it's convenient. Health systems love it. It doesn't cost them a penny. When I took my job 5 years ago, the main hesitation I had was, I don't like being yelled at. I don't like it when people don't like me. And I knew part of the job as chief medical officer was to go out and talk to physicians and convince them that we weren't bad. There were a few rough conversations. But you know what? They're all knocking on my door right now. Because they want us. They realize that if they can't lower the cost of health care, if they can't manage their population, they're going to be sunk. And right now, we are a gift to them because it doesn't cost them anything, and they get access to high-quality health care in the community and helps them with population health management and keeps down their primary care dollars. How many of you from Louisiana? Any? Yeah, a few. So it was just 2 years ago. I was down here, two and a half years ago, I was down here because we were about to open in Louisiana. I was asked to come talk to the Board of Medicine because as a group, they wanted to complain about MinuteClinic coming in and destroying healthcare. So, got beat up a little bit, not too bad, used to it. When we opened up, 83% of the people we saw did not have a primary care provider. Right here in Louisiana, 83%. The other thing was, we were talking to the board. They were concerned about quality. They were concerned about all of that stuff. After the meeting was over, 6 of the docs came up to us to ask us to affiliate with them. So the world is changing. All right, telehealth. So we need to evolve just like everybody else. We're constantly looking into the future. I really want you to listen to this because I think this is important for you. For us, nurse practitioners are expensive. And we have to see a certain amount of volume in a day to cover the costs of a clinic, which makes it hard to open up in rural locations. We also have some capacity in some of our clinics where the nurse practitioners aren't that busy. So we have deployed telehealth. This is the concept. Patient comes into a clinic that has a licensed vocational nurse. 2 years education rather than 6. They can do blood pressures, they can do vaccines, they can do strep under the order of a nurse practitioner. 85% of the conditions we treat can be done via telehealth. We've now seen over 13,000 patients in California and Texas by telehealth. We did, for the first, I would say half, 100% chart review. The quality was excellent. But what is most extraordinary here is the patient satisfaction, Cece. 95% of the patients were satisfied, but 34% of them said it was better care. Why do you think it was better? So the licensed vocational nurse hooked them up, was in the room with them, and sent the connected them with a nurse practitioner in another location. Therefore, the patient felt like they had a team taking care of them. In addition, because we used things like cell scope, the patient could actually see their ear, see their throat, listen to their own heart and lungs. So they were brought into the visit. And we thought it was going to be all the 20, maybe 30-year-olds. Our oldest patient who came through was 82, and we had the same exact distribution of age as our regular MinuteClinic, as well as satisfaction independent of age. So there are ways to reduce healthcare costs. So could you imagine sending an LVN into a home, hooking up digitally to a nurse or somebody else? That could increase your capacity and reduce your costs. There's lots and lots of ways to get out of the box and think about it. It doesn't mean poor quality. It doesn't mean you don't have a good interaction with the patient. It doesn't mean that the patients are not going to be happy. There's just lots of opportunities. So, questions do you have for me?
I like what you did with MinuteClinic, where you kind of disrupted, you will, the costlier office visit that was less convenient. But when do you get to your title? When do you get to the minute visit? I'm sick, and in the next minute, I'm going to get a visit. It's only going to take a minute, and it's only going to cost $10.
Right.
Now, who's going to disrupt you, or how are you going to get there?
So, how many people think we're stopping at that version of telehealth? How many people think that was our pilot test to be able to then take things home? To be able to expand MinuteClinic scope and hook up with a doctor? To be able to get into rural communities? That, my friends, was a pilot.
MinuteClinic at home, that makes more sense.
So, and I think that's an important point, is it's not about disrupting once, it's about a whole new mindset. It's about challenging the standard all the time, doing it in high quality, because people won't accept poor quality, but constantly evolving.
So I have two questions, Nancy. First, as I was listening to your discussion of the telehealth pilot, which was so compelling, I immediately started thinking about opportunities for this group.
Right.
And I'm just wondering if you've got some that you could discuss a little bit, possibilities.
Yes, so why don't we, I'm sure all three of us, let's take, so I mentioned very briefly, so where are your high costs? Put your high costs centrally and use lower cost opportunities. So, one, you can have an LVN go out to the home. Now, LVNs can't distribute medicines. I don't know, I didn't do the research, but I bet an LVN could put out the medicines, hook it up to their digital iPad, and have the nurse on the other side confirm that the medicines were put out appropriately under their license. Or the iPad could just be home with the patient. You might not even need to send the LVN. And then if they're using the blood pressure cuff wrong or there's a problem, that's the time to send them out. What other ideas do you have?
Well, one of the things that came through a little bit in our research was, again, home health having the ability to really expand its role, again, so that to be more of an early warning system. So you are in closer contact with so many of these patients and can literally, through sending the notes to the physician's records, for instance, or with a quick hookup via Skype on an iPad, say, Doc, actually, I'm here with Mrs. Smith, and I'm actually noticing this change, right away. Can we have a consult, that kind of thing. So spotting things in the environment, which again, I'm sure you're already doing, but actually leveraging the technology to make those connections so much faster, it seems to me. Yeah. It's another possibility.
And readmissions are such a hot topic these days. And picking up a change in weight, a change in vital signs quickly, and getting that patient taken care of before they need to be readmitted.
Yeah. Avoided readmissions are obviously extremely important. Looking at the technology, and you'll see a bunch of different technology in there, what you actually won't see is iPads. I don't think this group can afford iPads. $600 a pop. Those are the doctors buy iPads. Home care is going to probably use Android or free operating systems, which are starting to come out in tablets, and you can get tablets at sub $100, which are decent quality at this point. You don't have to pay $650. You guys have an important asset that for instance, MinuteClinic didn't have. MinuteClinic didn't have patients. It didn't have relationships with the patients. So if you guys wanted to disrupt MinuteClinic with your version of MinuteClinic at home, that could be an interesting collaboration. You guys have that asset. You have patients. And how do you actually start to service the patients? We've been talking mostly about medical care here, but a lot of what you do is social care. A lot of what you do is social assessment. The tools that we just started to mention are perfectly suited for social care and social assessment. So how do you combine social streams and medical streams and actually deliver a better service to your patients 24/7, 365 by using these virtual techniques that they started to talk to you about? They were able to do it with minor illness, minor urgent illness, and actually make a big difference. And citizens I'd be willing to bet a fair amount of your MinuteClinic business is cash. People actually just coming in and a willingness to pay. So that's what I want to start to talk to you about going forward. What's the services that you can develop with a willingness to pay with an unmet need in your community? Stop thinking about government all the time and stop thinking about who else. If you're going to do something valuable, the citizen's going to pay for it. We do it in every other aspect of our life. So you have the MinuteClinic. You were talking about online banking. The MinuteClinic kind of reminds me of the ATM. It was 24/7. But then you said, no, I don't need cash anymore, and I do the banking from the Roosevelt Hotel at 2 o'clock in the morning. MinuteClinic at 2 o'clock in the morning from the Roosevelt Hotel, that's what I need going forward.
So, but along that line, see somebody who has that sore throat. Right now, you can't prescribe, but you hook up with a MinuteClinic because we have the infrastructure. The PCPs who you're working with don't have the infrastructure. Get that patient's prescribed with the antibiotic that they need.
I think there's also great opportunity in the behavioral health area, which you're starting to hear more and more attention from, I think, payers in particular and providers that are taking on risk, because now as they have to care for patients and think about total cost of care, that behavioral health piece can become a very expensive and complicated additional element with so many of these patients. So for instance, Carolina's health system, they are going to a model of integrating behavioral health into the primary care setting, but doing it almost entirely with telehealth. So again, as you think about some of your populations, that probably a certain number of them also have these behavioral health issues, are there some opportunities there for doing the remote type consultation group visits, for instance? I was with an entrepreneur up at Harvard last week who is doing maternal group visits. Now, I realize that may not be your target population, but it's a good example of ways to think much more outside of the box when it comes to care delivery.
This is spot on. The single biggest comorbidity is depression, and it affects everything, and we haven't talked about it at all. And again, you guys have the relationships. You guys go into the homes. You guys get to know people. You're going to figure out they're depressed. When us poor PCPs, it's kind of, oh, you're thinking about suicide. Then I get it, It's got to get extreme. So now what could you do? How many of you have Facebook pages? How many of you take advantage of Twitter? I mean, you go on Twitter, my patients don't. Your patients are starting to use Facebook, and they're starting to use these tools because it keeps them in touch with their families. And it's actually incredibly easy to use. And you were talking about sensors and a strep kit, and then you mentioned genomics just briefly. The sensors are getting to the point where I don't need anything other than the same exact test that the doctor uses in the office. I mean, where would you get a pregnancy test done? I don't go to the emergency room to get a beta HCG done anymore. It just doesn't happen. I pee on the stick, not the phone. And boom, it works. So the kits that you're going to start to see that come out that are bug specific for diagnosing strep, wound infections, Band-Aids that change color, we're all within 5 years of these things. So you want to start building an infrastructure that allows you to take advantage of the fact that as these sensors come on board. How many of you thought you could do a home spirometer, a home blood pressure cuff, a home INR? I mean, those things are becoming available, albeit still a little on the expensive side. But I'm in technology. I'm telling you, the price comes down 50% a year, if not more. Those technologies are going to be widely available. And then would you go to the doctor when you did a home strep kit that said, I got strep, and he says, I'm not prescribing unless you come see me? No friggin' way. I'm going to the mail-away pharmacy in Canada and have it cross the border and get my penicillin the next day. It's not going to happen.
And with the change of healthcare payments, the doc is going to be able to prescribe it because that's the most efficient thing for them because they've already been compensated for it. So.
If they're in an ACO or any kind of capitated model, which is why we keep talking about Kaiser, that totally makes sense. The combination of sensors, EMRs, clinical decision support systems, social media, these are the things that are coming together that are going to transform your business. Not just the video conferencing, but all of this.
We turn it over to you.
All right. Well, I'm Dr. Mark Blatt. I'm Intel's Worldwide Medical Director. And yeah, disruption is kind of what happened to me. So I'm going to start by trying to talk about prospective payment and how that allowed you for the last 15 years to experiment like no one else could in the country using capitated payment models and what that did for you. And the assertion I'm going to make is that for many things, non-face-to-face care is not just as good as face-to-face, it's better. It's more convenient, it's more available, it's quicker, it's more timely, and it's more likely to be accurate and less harmful to patients. We keep talking about quality. In the Journal of Patient Safety about 2 years ago, a nice little study came out that might surprise you. Hospitals kill about 300,000 people a year. You're keeping people out of hospitals has a great deal of value. Hospitals, by the way, if that number is accurate, and it was a pretty good retrospective analysis off EMRs, cancer kills 600, heart disease about 600, stroke about 190. Hospitals are the third leading cause of death. Keep your patients out of the hospital. That's what you guys can do. Now I'm going to start and show you a quick little video that goes into, you have to back up probably one slide to roll the video, that talks about what I think nurses can actually accomplish. Yeah.
Nurses, the true heroes of healthcare, serving many roles: clinician, patient advocate, teacher and coach, friend. And as the healthcare professional closest to the patient, nurses are uniquely positioned to help us meet today's global demands to improve medical outcomes and the patient experience while reducing medical costs. At Intel, we've already seen how equipping nurses and their patients with the right technology can help achieve those demands, transforming nurses from heroes to superheroes. Let's start with what's most important to nurses: improving patient outcomes. Information is the greatest asset you can provide nurses: accurate, timely patient data. Patients using the latest connected wearable and sensor technologies can provide that critical data, empowering nurses to know exactly how each patient is doing in real time. This can be especially valuable for visiting nurses caring for patients at home. If a patient's condition worsens, nurses can be immediately alerted on their mobile devices to take corrective action. Even small downward trends can be spotted earlier, enabling nurses to prevent bigger problems from occurring. Nurses can also use technology, like tablets and 2-in-1s, to provide information to patients, to educate them about their conditions, in a facility or at home, and help patients help themselves. Best of all, technology is helping nurses connect and be closer to their patients. For example, tablets enable nurses to have more personal, face-to-face conversations with patients. Nurses can update medical records using touch and voice without turning their backs on the patient to enter data, and without the increased risk of error that comes with re-entering handwritten notes. As the standard of care evolves, nurses will use video conferencing to check in on patients and bring in doctors, specialists, and family members to take a comprehensive real-time team approach to patient care. They can also use social media to coach and encourage patients managing chronic conditions. Those same technologies also help reduce cost, without compromising our nurses' primary goal of patient care and wellness. Nurses can help more patients with greater efficiency, while still increasing the level of interaction with each patient. Our job is to design the right technologies and solutions to empower nurses to provide the best possible care, whether working in a facility or visiting patients outside the healthcare organization. Our processors power a wide variety of high-performance, slim, and lightweight designs with extended battery life, from tablets to touch-enabled 2-in-1s that boost productivity while reducing ownership costs, and with built-in security and collaboration features to help minimize threats and encrypt your patient's sensitive data. Want to find out more about how Intel-based solutions can help you connect more closely with your patients and better care for them while working more efficiently? Just visit us here on the web.
So the idea here is the different aspects that I was talking to you about, bringing in social media, bringing in connectivity, bringing in home sensor modeling, and thinking of yourselves as the orchestra leaders, as the team leaders that put together these teams to do these extraordinary things. You know, when I talk to doctors, I tell them, if you think your job is sitting in an office waiting for sick people to show up, you're about to get blown up, because that used to be your job in the 60s. And if you think your job is to sit and wait for hospitals to give you referrals to take care of your patients, you're about to get blown up. Healthcare reform is going to dramatically change the hospital infrastructure in this country. As we move from fee-for-service more and more to capitation, and we're at about 20 to 25% right now, so we're past the tipping point. And the bill that was just passed, the repeal of the sustainable growth rate formula, had set goals in it that went to 30 and 50% by fiscal 2018 for alternative payment mechanisms to Medicare. It's over, guys. And if you're not planning for it now, you're going to be one of the hospitals that go out of business. Half your owner-operators are going to disappear in the next 5 years, 10 years. Okay? There's going to be massive consolidation. And with your work, we're keeping people out of the hospital. So my bed days of care are going to drop dramatically. The locus of care is dramatically shifting outside the hospital. I'm reducing readmissions, yeah. But you know, the same exact techniques I can use to reduce readmissions, I can use to reduce admissions. And I'm seeing that over and over again in various countries. I'm the worldwide director. The Nordics, Norway, Sweden, etc., the 4 countries up there, they've reduced their number of hospitals by 75%. They're down to about 35 large hospitals in Sweden at this point. Reducing admissions and readmissions is important. Increasingly, the other thing you're going to hear about is in reducing unnecessary trips to the emergency room by better managing chronic care. Especially if you're talking about nursing homes and long-term care facilities. One nurse is on at night, she's got, 100 patients. Anything spikes, anything changes, boom, emergency room. So looking at how technologies and how you could actually start offering services to non-traditional providers that doctors aren't necessarily looking at, and how nurses could talk to nurses to help each other organize those teams and LTCs and assisted living and independent living to avoid unnecessary trips to the emergency room. By various estimates, 80%, 90%, certainly more than 50% of people who end up in EDs don't belong there. So all of this is coming together. Intel did the same kind of survey that you saw from Price. We asked about what's going to happen to hospitals going forward. This was a survey in 12,000 people in 8 different countries. Whoa, this is where you get your referrals from. You're in trouble. Okay? Video conferencing, 75%. Oh my God, we're going to take the personalization away from it. It's going to be, I'm a family doctor. I started out wanting to be Marcus Welby. I don't mean to be rude. Marcus Welby's a TV show. It's the 1960s. He's dead. Let's move on. I can give much better care now, much more personal care using things like video conferencing. Because when you get sick or you have a question at 3 a.m. and your daughter's worried or your son's worried about you, that's when I want the answer. I want it immediate. What your patients want from you is fast care. They want convenient care. They want affordable care. And going back to the errors, they never, ever want you to be wrong. It's nice if you're touchy-feely, but those are the things that they really need from you. Okay? We're talking about the sensors and home testing and bottles and pill bottles and everything. Patients want this, and it's coming. They're buying all those sensors. No one's supplementing them. No one's giving them grants. The government isn't paying for it. Best Buy is selling them en masse. You can buy them on Amazon. And all of these devices are... What could you do with a patient wearing a home pedometer? Just the only thing you knew about that patient was how many steps they were taking a day. And the steps went from... their normal 1,000, 2,000 a day as they pedaled about the room, the house, the apartment, went down to 50. It isn't even a physiologic monitor. You don't have to go to the FDA. It's a pedometer. These sensors are coming, and the home test kits that we were starting to talk about, they're starting to come in abundance. And we're starting to see them more and more overseas, quicker and quicker. So these technologies have lent a path, but you need a way you're thinking to get paid. That's the first thing. Well, Independence at Home Act is a huge opportunity for you guys to work with NPs, practitioner teams, doctors, organize care, and go into people's homes and still make milk fee-for-service until it dies, because there are CPT codes for Independence at Home. And they're actually more valuable. It's not waiting for a referral. It's doing outreach to the community. It's going to the hospital and saying, we can prevent unnecessary trips back to the hospital. We can manage your chronic care at home, your sick patients. The community care access-based programs at home. There's like $500 million in funding out there for these programs. And you can organize them, and again, they're looking at how to organize social workers, healthcare workers, nurses in community teams to avoid readmissions. And it's all funded right now through ACA. The PACE program, again, not available in every state. It's a Medicaid program, but again, it's designed to keep people out of nursing homes, not out of hospitals. It's designed to take people who are nursing home eligible, either through mental or physical issues, and keep them at home. And you know what it pays? It pays up to $5,000 a month in capitated funds. And it's reduced admissions to nursing homes by 30%. So there are a lot of alternative payment mechanisms. And again, the prospective payment system has allowed you guys to experiment with what works in virtual care and virtual visits and home monitoring for 15 years. You as a group probably know more about that than anyone in the United States. So then I'll come to my thought. Why aren't you starting to offer services that people actually pay for that are affordable? You know, you think of your customers, that patient, but your customer is the family. You guys take care of families. You're nurses, you're family oriented. What would a son or a daughter pay to know that mom was safe and monitored? Well, hey, that's an interesting business to get into. How can I start to feed information? What if I opened my records and charts up and they simply were able to read the notes? Ooh, that didn't cost anything. All that cost was a portal. Here's a login. Your mom gave permission. You can read the notes. And every time I come, you can see what exactly I said. Maybe you won't understand it all, but we did this in medicine, open notes. Did it at Mass General, actually. And it actually improved med compliance in patients about 70%. It had an amazing outcome, and the doctors came to accept it. So now you see how these technologies start to map up. They start to map up with the home sensors, the tablets, the intelligent systems, the business. These are the things that are avoiding the admissions, avoiding the readmission. That's why these technologies make sense to you. That's why you want to start to experiment with them. Not because they're cool technologies in and of themselves. Here's a cool technology I want to make you aware of. It's called the 3D camera. They just started becoming available. And you can start to see them in tablets and small form factors, the 2-in-1s, the detachables. A 3D camera, what the heck am I going to do with a 3D camera? Well, what a 3D camera does is if I took a picture of this room right now with just one 3D camera, I'm able to then focus on any place in the room with that one picture. I can change the focal length. So I could zoom in on your face or your face without having to take the picture over again. What could that do for me? Well, here's one simple thing, taking a picture of a wound. We did a demo at that technology conference CeCe mentioned last week where we were taking pictures of wounds and we were measuring the volume of the wounds because it's 3D. So now you send out a wound care nurse, you have somebody doing wound care, you take a picture of the wound and she's going, yeah, does it look better to you? We drew these little pictures in the charts and we decided, 4 days have passed and I pretend I remember everything and it looks better. Now the volume is being measured. Now volume isn't the only thing. You could have pockets, fistulas, but it's a pretty darn good measure. Ooh, maybe the patient could even do this. Maybe I wouldn't even have to have a visit. Because I can take that 3D camera and rotate it around the room, I could take a 3D picture of the room, then ship the file back, and you guys could do something like, home safety assessments. Oh, you could figure out where rails go, bars go, remove electrical outlet, cords, fix the rugs, and you could do all this remotely because the patient was using the 3D camera to scan the room and send the file back to you. And you could then look at it a month later or a week later to see if things have reverted, if they're not using the innovations. Maybe you could partner with somebody who could actually come into the room and do. You could give them the data, you could give them the safety plan, and then I was at a hospital system in Japan. People were coming in to be admitted for hips, and they had little telemonitors at the bed for ordering food, watching TV, soft phone. One of the other things they could do when they came in for their hip is they could redesign their house, contact the general contractor, put in all the ramps and everything, and it was ready for them when they left. Hospital was getting a cut of that as a service, kind of like leaving your car at the airport and getting it detailed. You can start thinking about services you could offer your patients that they would be willing to pay for that would have value that has nothing to do with the government. Like I said, getting the family involved, loneliness. What if you started using video conferences to actually not only diagnose remote situations like you see here, like a kid at asthma at home, an EMT shows up, the EMT calls the VNA. The EMT says, hey, I understand this patient's under your care. You open up a third video conference, maybe with an ED doctor that you're affiliated with or a Minute doctor that you're affiliated with, and then you decide, you know what, we're not going to transport this patient. We're going to nebulize him at home. We're going to give him a shot of Shalu-Medrol. We're going to monitor him for 20 minutes, and then you can do all, but that's not sitting there waiting for referrals from the hospital. It's not the doctor waiting for sick people. It's coming up with new business models and thinking about new ways you can proactively go out into the community and offer services. Again, I think getting family members involved. What if you offered video conferencing services to your lonely patients using tablets and tablet technology? $100 Android tablet. Join our virtual Friday afternoon coffee clutch. I don't know, charge $10 a month for it. You get 1,000 patients in it, it starts to become interesting money. And more importantly, they're now connected to you and they start to trust you. And they start to think of you as the glue that pulls people together. And that's what I meant about virtual care is better, more timely than face-to-face care, because you couldn't do that in the real world. They couldn't all get out and drive in a car and come to the clinic. That's too hard. But what if you came into their living room? This is an architecture for the sensors. So now you want to start thinking, maybe I want to partner with someone who knows something about IT, because IT is going to be really important to my business going forward. I want sensors in the home, maybe a home gateway of some sort to transmit it, a dashboard to look at the information. I don't even have to have the nurses in one place. They could be doing it anywhere. This is web-based. You can be remote. Nurse could be working from their home. I don't need a bigger office to do this. I just need willing bodies. I need a technology. And now I need a way of interacting and doing remote care, home care. And again, you can do this into long-term care facilities, assisted living. Partner with the community's facilities and services in the community that you're already in. Go back to the LTCs and the SNFs and say, hey, look, maybe we can help you with a problem. We've got a bunch of skilled nurses. We've got relationships. We know how to keep people out of the hospital. Maybe that service becomes valuable. And here's a whole bunch of booths that are actually cropping up. Remote care telebooths. So this is kind of the competition to the MinuteClinic, and quite frankly, I could see the MinuteClinic replacing the physical clinic, because you probably take about 100 square feet or something like that to do it. These take up about 35 square feet. So they're more cost efficient, they're getting better and better, they're getting more and more virtual. But here, you just walk in and most of these are cash on the barrelhead. They're put in places where people want convenience. They'll go swipe their credit card, spend $45 and get a visit. Okay? And there are more than just one kind of them. So the message here really is think differently. Think how you can start to design, develop, and deliver services that your patients might actually pay for. The loneliness counseling, the exposing the information to the family members, I bet your mom is safe notes. Think about what your patients really want from you. They want convenient care. They want 24/7 access. How many of them you offer 24/7, 365 access? You're not just there during business hours. That's what your patients want. How can you do that affordably? How can you start using automated attendance and work off the capitated payment models and share payments with ACOs, Medicare Advantage plans, the PACE plans, the community assisted care plans? The tools are out there right now if you develop and deliver these services at such a low cost that people can actually do something in healthcare that they haven't been able to do for 50 years. They can actually afford the service you might offer them without needing insurance. You have the relationship, you have the people in the community, go out and do something wonderful. Thanks.
So Mark, that was very inspiring, but it sounds overwhelming.
It is.
Now, you know, I'm sure a lot of these groups are cash-strapped, capital-strapped, don't have an in-depth IT department. How would you advise them to get started?
Well, I was trying to be a little overwhelming. I mean, I had 17 minutes. It was shock and awe, guys. I wanted to kind of give you a little bit of a breadth of where you might go with this. But I was serious about exposing your notes and exposing your charts. If you have online records and you want to start to draw patients in, how would you, I mean, the way Epic succeeded in letting Kaiser do their virtual care visits was MyCharts. And then everyone brands MyCharts in their own manner. But all of a sudden, patients can schedule appointments online. They can look at lab. If you can start to be the conduit to say, hey, we'll go get your lab tests and we'll put them up online and you can come see them. Now your patient doesn't have to think about 12 other, she's tied to you and your website, your branding. So simply develop a website, a Facebook page. You got to do it securely. You got to be HIPAA compliant. You saw that stuff thrown into the video. These tablets can do these things securely encrypted end to end. But I think the way to get started is open up your data and start to draw your patients, your family, and the extended family members into that data web. That costs nothing. It's just a new way of organizing your thinking and a new way of doing business.
And the extended family would pay
I think
for the access.
Yes.
Oh, yeah.
Yeah, if you turned around and actually said, you know, for the patient, the portal's free, but, you know, I don't know, trivial number, $3, $4, $5. Guys, this is software. This is incremental revenue. You got 100 patients a month, it's an extra $1,000, and you did nothing. That's a way to kind of get started to see what might happen.
You know, I would also just chime in on that one that we see many organizations in exactly that situation that you're talking about in terms of cash strapped, don't know where to begin, and often you can start by partnering with some other organizations. So whether it's a large health system that does have the capital and the infrastructure from a technology perspective or staffing perspective, or a digital startup, or a community. I'm sure many of you are already engaged in low-tech partnerships in your communities. So now this is just thinking about some additional potential partners out there, I would think.
I think some of your potential partners are people who also want to keep people out of the hospital. And like I was saying, the LTCs and the SNFs. Who gives care to them in the middle of the night? And if any of you as nurses have ever been on duty in one of those, you know what happens. As soon as anything goes wrong, boom, hospital. It's not a great way for the patients. You know, they're often infirm, demented, slightly confused. It's not a great evening experience to spend 6 hours in a hospital gurney to treat your UTI, okay? Could you do something with them to actually start offering services, to extend their care, to extend their ability to deliver services? Start thinking non-traditionally, and start thinking about psychiatric care, and start thinking about social media. If you want to change, you were talking about smoking cessation and changing behavior. If I wanted to change your behavior, the person I'd get after you is your husband. Well, I'd get your husband after you, and I'd get your kids after you.
Right,
I'm a family doctor.
Right.
I used to call it SOS, spouses, offspring, and siblings. I'd sick the family after you. I know it kind of violated HIPAA, but it worked. You know, and I had your tacit permission to somewhat do it. Okay? But now you got social media. With patients' permission, set up Facebook pages for your patients. And then on those Facebook pages with the right security and the firewall, put only their family members up on the wall. And now you've got a secure media you invested nothing in for actually communicating with your patients.
Mark, I wanted to follow up on the wearables conversation because in some of our research, we had a couple of interesting insights from consumers. One is they don't want to pay much, if anything, for it. So when the price of the Fitbit, for instance, that I'm wearing gets above, say, $100, you see a drop-off in people that want to shell out that kind of money. They're much more interested in having an employer or an insurer purchase the device. They are enthusiastic in the beginning, and then they stop using it, right? And also, I think there's a broader societal concern that those of us that probably need the intervention the least, those of us who are probably already active, and those of us who have some financial means are the adopters. And so I'd love to get your thoughts in terms of how we flip that around and get them to the folks that really need them.
We're working with a multi-line insurer right now in Australia. Okay, and they do not only health insurance, but life and disability insurance as well. They're willing to offer discounts to their customers if they'll wear a smartwatch that measures footsteps and heart rate. Basically, because if their footsteps fall off and their heart rate patterns start to change, they know there's likely going to be a disability claim. And what they've seen is a lag from the event to the time of the capital allocation occurs of up to 6 months, and it's a very inefficient use of capital. Now, all of a sudden, by offering you a discount, and I can drag that time into 2 months, so the way I got the patients incented is I offered them a discount, and I think you're going to start to see creative insurance companies. So next week, or not next week, today, another group of my team is at the Blue Cross Blue Shield Summit in good old Phoenix, and they're talking to two of the Blues about using the same idea, because they're multi-line insurers as well, how to use smartwatches to decrease disability and detect things like workman's comp accidents, okay? And we'll pay them to do it. Now,
how do we get people to keep using them after, say, 3 months?
Well, if you're incenting them with a discount on their Medicare coverage plan, their
like a
their
Medigap
incentive plan, some sort. You're giving them credits or incentives through CVS. I mean, CVS also offers some interesting incentives for refills and to come back, and reminder systems. You've got to make it worthwhile for people. You got to make it easy. And I'm with you, confused about why people won't pay $100 for the Fitbit and are paying $70.99 and up for the Apple smartwatches, and they out-ordered them in 3 months. I mean, maybe it's just Apple. I don't know. But these things are becoming commodities. There's the Pebble watch. There's the Fuel Band. And as clinicians, we might say, well, how accurate or how real are these? JAMA had an article 2 months ago, and they compared about 15 different ones. They counted footsteps. They weren't counting heart rate, to be fair, but they looked at footsteps, and the only one that actually fell out of parameter was the fuel band. All the others actually were pretty accurate. So this technology's coming. It's real. It's going to get better and better. That virtual camera I showed you, think about a 3D camera in the patient's house again. One of the scenarios we were working with a home care provider was they were talking to the patient but then zooming in on everything in the house, and they noticed the house was in disarray. And again, they were able to assume that the patient might be depressed, the same as you would by walking into the house and observing everything you observe. What could you take a picture of what's on in the refrigerator, what the shopping looks like, what the bathroom looks like. Start to use this technology differently.
So Mark, the other thing you were, sorry for interrupting, but earlier you had mentioned SOS,
Yes.
family and the support.
Yes.
So I certainly know, I have a Fitbit, my daughter has a Fitbit. I know when she isn't using her Fitbit. And it's like, okay, this week, on Friday, I'm going to
That's how
meet
you
with
change
you.
behavior.
And so you guys, as well as the family, can be that motivator, because it's not just the financial incentive,
Right.
it's the interpersonal incentive. And it's so ridiculous, but when you get that little smiley face, or you get the,
Here's your week.
here's your week,
Yeah.
or when you hit the tree, the redwood, you climbed a redwood today. It's stupid, but it works. So,
Absolutely.
so it's not all about the money. I don't think you have to create the financial incentives for people to use it, but if you're on the other side saying, way to go, you had a great day, or I'm worried about you because...
Well, and I was going to say, I'd love to hear from you too, but I think baby boomers are also going to drive a lot of this. Either themselves, it's a generation, frankly, that hasn't stood for anything exactly the way it is. They have literally changed the course of history from their birth. Think about civil rights, Vietnam War, et cetera. So baby boomers, why do we think baby boomers are going to be satisfied with this fragmented, costly, inefficient, impersonal healthcare system as they age? And think about, my mother's in Naples, Florida. She's golfing. She's playing bridge. I would like her to
She plays bridge with my mother. She plays bridge 4 times a week, 82.
I want her to stay in Naples, Florida, golfing and playing
And you
bridge.
would pay for a service
I
that told
would.
you how well she was.
Absolutely. If I
Exactly.
could keep
Anyone
an
in
eye on
Naples?
her steps or see her pacemaker results, I would absolutely pay.
You would probably, even with mom's permission, secure a webcam.
Oh,
That might, when you push the PERS button, instead of I've fallen and I can't get up and EMS comes out, what if when you push the PERS button, the webcam goes on and it sends a call to the 24/7 monitoring stations in your office? And now you offer a service that augments PERS. If you don't do it, ADT is going to do it. These things are going to happen. All of them are going to occur to use social media, remote monitoring, cloud business intelligence, EMRs, sensors, to devolve care into the home. Hypertension, COPD, diabetes, dementia, wound care, all of these things are going to change, and they are already starting to change. And if you don't do it and you just sit there and wait for referrals, good luck.
So Mark, why don't we let Tammy come up and get some, Tracy.
Can you tell we're
to get
excited about this
some,
topic?
questions from the audience. We've been chatting
I can't thank you all enough. I love the phrase shock and awe. This was an hour and 45 minutes of shock and awe. And what I loved most about this is that every single solution that you offered, and I'm going to have to go back and watch and list them all because I lost track, they're proactive. You're not waiting around for somebody to give you a referral, offer you part of a bundle, or tell you what you need to do for their patients. This is the business model of the future for this industry. This is where we need to be focused on reasserting ourselves back into the community-based care system that you originated. And I can't thank you all enough for this. And I'm dying to get to questions from the audience. I know there's got to be a lot out there. I really appreciate the fact that you all would sit and listen to these experts offer us these types of solutions. So let's open it up to questions from the audience. I know we have a mic in the back. Who has the mic? Hank has the mic. If you raise your hand, right up here, Jean Parker Martin has a question. If you don't mind, please, just so we can make sure everyone can hear you, Jeannie.
I have two. Is it working?
Yes.
Yes. I have two questions. One for Nancy. I'm very curious, Nancy, in your affiliations, if you have any examples of work that you're doing with home health agencies or hospice providers. If you do, it would be great to give maybe an example or two. And if not, are you thinking about working directly with home health agencies or hospice providers in some of the examples that you gave?
So I wish I could say yes, but I think this is a great opportunity to connect afterwards and to think about what's next. We have focused on the more traditional, inpatient hospital systems, but I think we're poised to work with other groups. So I think this is a great opportunity, and
Yeah, I
I'd
think
love
it's
to chat with somebody afterwards.
It is really, and it's very, very exciting. And I think the whole idea of transitioning to integrating home care and hospice providers would be really exciting with all of the clinics.
Couldn't agree more.
Then the second question I have is for Mark, and I'm just wondering, sort of in the same vein, within the context of home care and hospice providers, is Intel doing any consumer forums to test out some of these tools that you have that are very, very exciting that we've been hearing about now for, I think VNAA had Eric Dishman many years ago come and speak. Are you doing any testing with the old, like the 80 and 90-year-olds, the old elderly, to see how they're adapting to some of the tools that you're integrating now? And thank you all three for your great presentation.
You're welcome. And it's a great question, and yes, we are. Again, we're a worldwide company, so we have the opportunity to do things on grand scale. If you think we have an aging population, you don't want to live in China. China is where we're doing most of this age-friendly cities, looking at the China grid. They have a one-payer socialized healthcare system, which is much more rationalized than ours. So having people age in place in cities, because they can't build enough nursing homes for their population. So very much so. We have ethnography teams. We have architecture teams. Also starting a pilot with an organization in Cologne, Germany called Malteser. Malteser is a 400-year-old volunteer organization, has 8 hospitals, 20 nursing homes, 800 skilled nurses, 4,000 ambulettes, and 50,000 volunteers, all on one platform. You could actually be in an acute care hospital and write a Meals on Wheels order, and it'll go electronically to the provider. This is the first place I've ever seen this. So I've gone crazy with this guy at Malteser and said, what can we do with you for home gateways and home monitoring? I haven't seen the equivalent enthusiasm in the US. Love to talk to anybody here who might be interested.
We will be glad to talk with you about that. And Nancy, you're going to have a line of people to speak to you afterward. I think there are 2 opportunities here. You mentioned the allied systems that you're already working with, and at least 2 of the ones you mentioned are already engaged with VNAA. So let's work to get you through the back door with them. But then also to identify communities where you may have a broad geographic area that we have members that can help support you. So I see a great partnership
Absolutely.
with VNAA and some of our members as well. Hank, you have another question?
Thank you. My name is John Quinn. I'm the CEO for VNA of South Central Connecticut in New Haven. I guess, Mark, I'd address a question to you, and referring to the last slide you had up more or less of some opportunities and things like that. I want to take it home for a second. I want to take it home to inner city in New Haven. I want to take it home to our clientele, which is 36% Medicaid. And I want to take it home to our clientele, which is 46% Medicare. And a lot of discussion we had about self-pay. And there's not a lot of squeeze in that, in the reimbursement dollars for self-pay. And part of it has to be with the federal government also realizing what they should pay for, like Medicaid, paying for telehealth or not. And I'm wondering how much is Intel doing on the federal level to sort of educate our congressional delegations and the decision makers about this is the way to go. This will save you money. And where CMS is coming up with all these other things like sequestration to save money and things like that. But this is the real money-saving options. Yet it's not practical for an inner city agency right now to say that we can have the self-funding, or I like your SOS description. You know, those folks just don't exist in some cases. And if we did those Medicaid psych patients calling in every week for a session, there's no way to pay for that. but they were certainly taking advantage of that. So where do we go when you're working with the inner city and those kind of population bases?
Intel worked hard lobbying for independence at home, Eric Dishman among others, to get it included in ACA as a treatment option. I think, again, with the changes that you're seeing coming out of the SGR repeal and the movement towards moving people into non-traditional payment mechanisms at the Medicare level, remember they can't affect Medicaid directly, that's up to the state, but at the Medicare level, no one's a village. You're not going to be able to do this as an independent agency. Just as if I was sitting here talking to the American Academy of Family Docs, I would tell them the two-person office is dead. Get over it, move on. You need to coordinate care. You need to think of yourself, what's the best skills my group has, my nurses have? We're great at coordinating care. We're great at psychiatric referrals. We're really good at stoma care delivery, whatever it is. So how can you play your role in kind of an organization, and you partner with a social work organization. You partner with maybe a group of outpatient primary care providers in the Southern Connecticut area, and you say, we want to start to offer a new service. That's what it's going to come thinking as. You guys are closest to the patients. You know what the patient needs. They need Amulet. They need Meals on Wheels. They need care relief. You know what they need. And then you can be the expert and drive that new care delivery. You're not going to get it with reform and here's more money for doing what you've been doing. It's not going to happen.
One thing I would mention, though, with respect to payment for these things, because everybody that we talk to in healthcare describes feeling as if they have one foot on the dock and one foot in the boat. And it's very difficult to sort of figure out when you jump into the boat, right, and set sail, because so much of your revenue is still over in that traditional fee-for-service world. But if you take a look at what Congress and CMS has been doing the last several months, not only around moving away from volume-based payment to value-based payment, different incentives, shared savings programs, et cetera. There are lots of those. They also, a few months back, put in a lot of money, for instance, in the agriculture budget for internet broadband out in rural areas, and there are about a half a dozen new Medicare CPT codes that are for telehealth. So you are seeing recognition by the government, as well as obviously private payers, that they need to shift some of the money into these newer care delivery models.
Absolutely.
Yeah, I think that's a really good point, that also the ATA, the American TeleHealth Association, is putting a lot of effort into trying to get standardized regulations across the country. So something today may not be covered, but you don't want to wait until the law changes to start planning, that there's lots more opportunities out there than you might think. Understand your state regulations, and I bet there are some things you can do even with today's state regulations.
Well, and to Nancy's point, it may not be reimbursed today, but it is likely to be reimbursed or paid for by a commercial payer in the future. If you're already doing it, if you've demonstrated your expertise, if you've proven the value and the outcomes that you can achieve, you're going to be first at the table when the opportunity arises. John, I think your question was fantastic, and we do work with the folks in the Intel Federal Office, and we'll go back and redouble our efforts with them so that we're very closely aligned on our advocacy efforts. So thanks for the question. Next question? Hank, you have somebody? Great.
Andrew Bronstein from ClinLogica. We're a company trying to move people to some of these types of things and enable technology. One of the pushbacks I get a lot is this fine line, or maybe it's a big chasm between primary care and home health. And the not wanting to jump over the line or take on things that they feel might cause the physicians to react negatively. So questioning some of their treatments, trying to improve certain things that they might have traditionally seen as primary care things. But the physician sides that I talk to say, well, we're looking for home health to step up and take on more of these challenges. What's your perspective on, where that line is, where the physicians are relative to home health providers taking on more of that balance versus it's remaining in primary care?
I think you're seeing partnering more and more between home health organizations and primary care groups. I mean, to me, that's a lot of the definition of an ACO. It's more important to have that continuum of care. And it makes perfect sense to talk about it in the framework of a risk-bearing organization. because you're going to do something which the other part of the risk doesn't like, the hospital. You're going to keep people out of the hospital. You're going to keep them out of the emergency room. You're going to drop bed days of care dramatically. If I had to summarize the telemedicine literature succinctly, I would say it's safe and effective. It costs somewhere between 2/3 the cost of traditional care, and it drops all admissions to hospitals by over 50%. That would be a succinct summary. If I'm a hospital CEO, I'm in shock. It's the last thing I want. And one of the ways you're actually going to see this rising is the more FUD you hear in the general literature about how unsafe telecare might be, and it's not proven at all, but the more you hear it, the more I know it's actually making inroads. That's my soft signal that people are starting to pick it up.
Nancy?
So this is exactly the world that MinuteClinic lived in. When we started, the primary care docs weren't particularly happy thinking that we were taking away, and I've heard it all, cherry picking, skimming the cream, doing all of that stuff. And a couple of things happened. Number one was when we got into a community, 50% of the patients who we were seeing didn't have PCPs. So the PCPs started getting referrals from us. And when I reviewed my slide, you can see that a lot of the services that we have started to add on are really designed to augment, not to take away business from the PCP, but to do things that are costly for them to do, or make it hard for them to provide the great quality they want to. So augmenting by doing blood pressure readings in between their visits. So I think the PCPs are probably even more scared than any other group out there because their worlds are changing the most. And I think they're looking for partners and advocates. Having said that, don't be afraid. What's going to happen if they don't like you? You know, if you step on a few toes, the world keeps going on, and you make it that they need you more, the world keeps going on.
Cece?
Oh, I'm going to go. We have more questions. So.
Okay, so we have time for one more question, and there's a lady in the middle back here, Hank, that keeps putting her hand up. I want to make sure we get to her.
She's been very, very patient.
Yes, she has. You get the final question.
Thank you. Good morning. Kathy Pierce from the VNA of Care New England. I just had a quick question about telehealth and wound care. We find we do a tremendous amount of wound care in home health. Probably 60% of our RN and LVN visits are wound care. And we do have WOCN who reviews digital images, so we do that remotely. How do you see that changing with telehealth?
Go look at
Perfect.
that 3D camera.
Yeah.
I'm serious. The 3D camera is available right now. You can buy it on Amazon. I think it's a Dell Venue 8000 or something like that. They're $399 with the 3D camera. It's a still camera. Starting this month, motion cameras are coming out that will actually do in-depth review of the wound. Software to diagnose the wound to help you figure out, is it improving? The ability to then use a bidirectional camera and help a spouse or a family member change the wound dressing, and maybe a nurse comes in every third day or fourth day, and with guidance, someone, quote, watching over their shoulder, I think patients will be more and more willing to take on that task once they're shown how to do it, and then somebody encouraging them behind them doing it. So I think wound care is very much going to move online. Again, I'm a worldwide director. There's an HMO in Israel called Maccabi. They started telecare, and they started it with stoma care. And they started sending people home with tablets to do stoma follow-up.
I'm going to give each one of our panelists the opportunity for closing words, pearls of wisdom, bon mots, as we close out our session. Cece?
Well, I guess I'd like to share a comment that I heard last week by Mark Bertolini, the CEO of Aetna, which, you know, in some respects, that's kind of as traditional healthcare fee-for-service, large corporation, publicly traded, answerable to shareholders every single day as you can get. And certainly much of their revenue is still in that old world, but increasingly his focus and the company's focus is on the new care models, paying for value, retailization. He's got a pretty brazen prediction. I think something like he says by 2018, 80 million Americans will be shopping on exchanges, either public or private exchanges for health insurance, which is a pretty big leap from where we are today. And if you sort of probe with him, why are you sort of focused on all of that now? He will say, because we know that's where we're headed, and we want to be ready. We want to be the ones in the position when the when the light is switched and we've all gone over to the other side. We want to already be there, be comfortable, have our operations worked out, have the team in place that we need with the know-how, the analytics, et cetera, et cetera, et cetera. That's on a very large scale, but I think it's an interesting insight into a mentality that you're starting to see more and more in healthcare.
Great, thank you. Nancy?
Just to build on that, I think some of this can definitely feel a little bit overwhelming, and how do I get there? And it's not a leap. It's really okay to take the first step. The wound care, inexpensive tablets, start with who you already have, build onto it. You don't have to go from day one all visit-based to, okay, now we're going to do it all telehealth-based. Small steps, but keep walking in the direction.
Fantastic. Mark?
I'll say the rate of change is going to get worse. I didn't talk to you about avatars. I didn't talk to you about artificial intelligence. I didn't talk to you about genomics. This is the foundation. If you're not starting a foundation of communicating electronically with your customers and your extended family of customers, you're going to be left behind. So get started. Form some type of an infrastructure that allows you to do it. Choose whatever you want to start with. Choose whatever you're best at. But get started.
Thank you. Clearly, we'll have you all back next year to update us and highlight some new opportunities. What a fantastic panel. Thank you so much for joining us this morning. I'm delighted to welcome you to our coffee break outside in the back of the room immediately after this session closes, sponsored by Intel. And I encourage you to please visit all of our exhibitors to ask them what type of technology they have that can help you move down this road. Please join me in showing your appreciation for our outstanding panel.